The problem is that while mechanical ventilation saves lives, it also has huge healthcare costs and complications, such as sinusitis, injury to the vocal cords and upper respiratory tract, tracheal stenosis, hemoptysis, ventilator-associated pneumonia, and increased morbidity and mortality, all for which the risk increases over time. Mechanical ventilation is not only invasive, it is expensive, and in a busy ICU, ventilator weaning is often a low priority among nurses and physicians. The aim of this project is to reduce ventilator days in the trauma ICU by 25% within 6 months through implementation of a nurse-driven ventilator weaning protocol. Let's look at the evidence supporting this change. Evidence shows that ventilator weaning protocols are safe, easy to implement, and well accepted in the ICU. Protocols speed up the weaning process and decrease incidence of pneumonia and delirium. The use of a weaning protocol was found to decrease mechanical vent days by over 50%. A well-designed protocol decreases ventilator and weaning times, ICU costs, complications, ICU and hospital stay, ventilator-associated pneumonia, and improves survival. A protocol standardizes care by reducing practice variation, and there is more collaboration between nurses and physicians when a protocol is in use. So why nurses? Most importantly, this protocol empowers nurses, making leaders by putting power at the hands of those at the bedside. Evidence shows that weaning times can be prolonged when physicians aren't familiar with patients or if their schedule is too busy. In our trauma ICU, this is often the case. When multiple physicians are involved in patient care, there is often conflicting approaches to ventilator weaning, delaying the process. At ECMC, we rotate residents daily and attendings biweekly. Using a protocol, nurses can expedite the weaning process because we are more readily available. And nurses have fewer patients than physicians and can respond quicker to necessary ventilator changes, accelerating the weaning process. In a busy ICU, protocols allow physicians to focus on more critical patients. Because patients in the weaning process often suffer because they are deemed stable, the protocol keeps this process moving forward with minimal need from the physician until extubation. A non-physician-driven weaning protocol significantly decreases ventilator days and the associated risk of complications when associated to physician-driven protocols or those weaned by usual care. The model for improvement guided our quality improvement project. To begin, an interdisciplinary team was developed. This included the nurse case manager for the trauma ICU, myself, who was the team leader, the intensive care clinical nurse specialist, the director of respiratory therapy, the trauma ICU charge nurse, and the trauma ICU unit manager. Our interdisciplinary team held meetings on a routine basis, and our team developed a protocol with an easy-to-follow algorithm. For this project, focus was placed primarily on the role of the nurses. The primary time for the protocol to begin is between 0500 and 0700. Step 1 of the protocol. Is there a ventilator weaning protocol order? You will know by the presence of an intervention on our documentation screen. Step 2. Ventilator weaning protocol safety screen. This evaluates if the patient is hemodynamically stable, with no active seizures, no withdrawal symptoms, no agitation, no paralytics, and normal ICP. If the patient passes the safety screen, move on to Step 3. If the patient fails, the nurse re-evaluates in 8 to 12 hours. Step 3. The ventilator weaning protocol, the spontaneous awakening screen, requires turning sedation off and evaluating if the patient is tolerating weaning. Failure is demonstrated by a SAS scale greater or equal to 5, a respiratory rate greater or equal to 35, and/or showing respiratory distress, O2 saturation less than or equal to 88%, hemodynamic instability, ICP greater or equal to 20. In such cases, sedation would be restarted at half the dose and re-evaluated in 8 to 12 hours. Next is the spontaneous breathing safety screen, Step 4, which evaluates the patient's continued tolerance before beginning breathing trials. This allows the patient to adjust before breathing trials, uses the same failure criteria as the awakening screen, and if the patient passes, you move on to Step 5. Step 5. Respiratory therapy is notified to continue on with the spontaneous breathing trials, and ventilator weaning begins. Their nurse is responsible for assessment of the patient condition throughout the protocol, along with ABGs when necessary. The physician will be notified when the patient is ready for extubation, requiring physician assessment and order for extubation. Respiratory therapy is responsible for the return to previous mode of ventilation in cases of failure. To evaluate if the changes made were an improvement, we developed 3 measures. The outcome measure is our average ventilator days per patient. The process measure is nursing compliance with documentation. The balance measures are nursing satisfaction with the protocol, and added in later was the unexpected loss of computers causing added stress on staff. Our change implementation had 2 PDSA cycles. PDSA 1 was a short 2-week trial. Education was provided through read-in signs, email notifications of protocol initiation. A poster with the change process was placed in the break room, bathroom stalls, and physicians' rooms, and a screensaver was placed on all trauma ICU computers. Surveys were done to measure nursing satisfaction, and charting was reviewed to monitor nursing compliance with documentation, and the team monitored average ventilator days per patient. For PDSA-2, re-education was provided due to poor satisfaction scores, poor nursing compliance, and lack of significant change in ventilator days per patient. Nursing surveys were dispersed earlier to allow adequate time for return since a low number of surveys were filled out. And positive reinforcement was provided for nurses who properly documented with kudos cards. These kudos cards are worth just under $4 in our cafeteria and gift shop. Unfortunately, days into PDSA-2, ECMC got a computer virus and we lost access to all computers. We originally attempted to continue the protocol, however the decision was made to place the protocol on hold. We found that attempting to add change during an already stressful time was doing more harm than good, and could potentially hinder the protocol in the long run. One facilitator to the change process was the protocol's easy-to-follow algorithm. The nurse-driven protocol also empowers nurses. This became an important part of the education provided to staff. Having the unit manager and charge nurse part of the team encouraged adherence to the protocol through leadership example and endorsement from those with power and authority. Having strong evidence supporting the change process showed staff that the protocol could and should be done. The barriers to spreading change included nursing resistance to change. Overcoming this resistance required re-education to staff. There was also nursing resistance to the increased documentation demands. This also required re-education to staff. The loss of computer access due to a virus during PDSA-2 was our biggest barrier, and since we couldn't overcome this barrier, the decision was made to put the protocol on hold, with the plan to resume after the computer problem is resolved. We expect a positive impact on practice and quality improvement. The average ventilator days for PDSA-1 showed no significant change from the previous 6-month average. The average ventilator days per patient for the previous 6 months was 9.15 days, and for PDSA was 9.29 days. For PDSA-2, we attempted to keep an accurate hand count, however decided to place the protocol on hold. And we propose that PDSA-3 will be 25% lower than the average of the previous 6 months. The nursing compliance with documentation for PDSA-1 showed only 35% compliance with documentation. Our second PDSA was placed on hold, and we propose that PDSA-3 will be at 80% compliance once the computers are up and running and nurses have become more familiar with the protocol. For PDSA-1, we had only a 45% satisfaction rate. Our second PDSA was placed on hold, and we propose that PDSA-3 will have 80% satisfaction rate by nurses by giving nurses more time to fill out the surveys and allowing more time for the protocol to have an effect. I look forward to continuing this project. One thing I would change for PDSA-3 is the ability to pull out the chronic vent patients. ECMC currently uses computerized reports that don't account for these. Thank you so much.